Halito. Halito, that's greetings in Choctaw. I'm on both sides of my family. Choctaw, probably not enough to get the card, but I wanted to introduce this section on culture. Now, the reason I'm doing this, and I'm recording this in advance, because I won't be with you this week, but this is a critical subject that I feel that the field has really just started beginning to address. So, what I like to begin with is talking about a phrase that came from a fellow practitioner, Hugh Vasquez. You may know him on the Lee Manoir film, The Color of Fear. What you probably didn't know is that Hugh is an addictions practitioner, and he wrote a piece in the early 90s called La Cultura Cura. Now, and it simply means in Spanish, if you're not bilingual, culture is the healing stuff. Now, the reason that culture is the healing stuff is that everything happens within a cultural context. Part of what the field deals with as part of what goes on in treatment, it happens within a cultural context, but it doesn't necessarily recognize that culture exists. Now, culture is a large pattern of behavior that's applied to humans, but in our English-speaking world, often when we speak about culture, that's usually a code for race and ethnicity. And they will talk about the African-American culture, or the Hispanic culture, or Native American culture, and not necessarily talk about what's going on with Anglo or European American or treatment culture. And so the basic idea, when Rasmussen talks about multicultural populations, she does it late on in the book. When ASAM considers culture as a dimension of recovery, that's part of recovery, way in dimension 6. Now, one of the things that you deal with when you're using a trope that is a metaphor about dimensions is that dimensions coexist. You're not necessarily supposed to consider the dimensions, 1, 2, 3, 4. So one of the things that we find as addiction practitioners of color, you have to go to the root of the person's pain and suffering to deal with it. And one of the most obvious roots that we often deal with is the question of race and ethnicity. So when I'm talking about culture, I'm talking about more than race and ethnicity. But functionally what happens is we tend to look at race and ethnicity first, and maybe sexual orientation, other aspects of culture, socioeconomic status, etc. And when I'm talking about culture, I mean more than that, more than just simply race and ethnicity. But paradoxically, I'm going to talk about race and ethnicity because it isn't being done in the field, and it's often one of the most difficult and intractable problems. So, as an example, the science says that people are self-medicating for their addictions problems. And because they're self-medicating, they are often using external chemical to cover up their feelings of anger, depression, whatever, that might be generated by other causative factors. So as an example, and I tend to use real-world examples, a biracial, that's our code name for a person who's one of her parents is black and one of her parents is white. Biracial person raised in this community, okay, who was a student at this college, was sexually abused as a teenager by her racist white stepfather in Springfield. It wouldn't matter in Springfield, I'm just using that particular example from her life. It's not a composite, actual person, but there have been many of her over the course of my career. So part of what she was dealing with was being called nigger bitch while she's being sexually abused. So that means that race and gender and sexual trauma are being combined in this one person, and that's driving her drinking. And when I saw her, I made the appropriate referral to treatment and suggested long-term treatment. Well, one of the challenges with 12-step based treatment is that racism isn't part of the construct of 12-step based treatment. And if the experience of many clients of color, when they raise race as an issue for their wounding, for what drove them to drink or use, they are shut down. Which means that you're setting them up for relapse. So, and they're not being shut down because they're not raising a legitimate issue. They are. They're being shut down because the counselor feels uncomfortable with the subject. All right? So within black psychiatry, that is the science that has basically been built up over 150 years, parallel, because remember, in the early days of this country, as well as 150 years ago, African Americans in particular were not considered citizens or fully human or worthy of considerate of psychology or even normal. So we had to develop our own science basically to deal with living in a racist society that supported slavery or supported segregation. How do we make a healthy transition? What does a healthy psychology look like for us? So just like we don't have case law that involves sexism or sexual discrimination until women enter the legal field, so we don't also have a psychology of how you deal with racism until people of color enter the psychological field. Now, to this day, the American Psychological Association does not recognize that there are any emotional consequences or repercussions for race within DSM. There is if you're gay, gender identity dysphoria. There might be if you're women experiencing sexism. But as I was talking with one of your students, how many men acknowledge the existence of PMS? Right? Not in their worldview. Does APA recognize PMS? Probably not. Until women scientists get together and catalog, signs and symptoms and, treatment. Not that it needs treatment, I'm just saying, Freud basically thought women were crazy. Hysteria. Okay? That's discriminatory science being policy. If people think that that the normal psychology is middle-class white men from Europe, and everybody has to act like them because that's normal, we got a problem. All right? So part of what we deal with la cultural cura, the underlying expectation. Okay, you're taking this class to be able to help people out with their unresolved or untreated problems. Now, for example, since racism doesn't exist, according to the American Psychological Association, that's going to be an untreated problem for people of color, especially in a state that was set up to exclude people of color to begin with. The state of Oregon was basically formed to exclude black American citizens from coming here at its founding. Okay? No people of color were allowed to live within the city limits of Eugene before 1965, legally. All right? So that has a psychological impact. Right? So this means, for example, in terms of untreated, you can't have the same untreated problems that they have or untreated major problems while taking the class because it'll be intellectually and emotionally rough for you. So even having the conversation about talking about racism with largely white practitioners is difficult. All right? So in terms of taking this class to help yourself with your own problems, one of the ethical conditions of this field is that that anybody within the field be able to address racism. Now, the reason I'm talking about racism in terms of a study of culture is that is often one of the major barriers to treatment. So that woman that I told you about, who was in treatment with 5 other black women at a local treatment agency that treats women, they were supposed to be there for 3 to 6 months. They were all discharged inside of a month and a half for raising that same issue. Race as part of their psychological wounding driving their addiction. Now, in the state, there are treatment agencies that do allow you to talk about racism. So, should I only send black people to Portland? No. I don't have the option of treating white clients or people of color. I treat everybody according to their racial wounding or not, whatever the primary issue is. So the underlying expectation of this class is that you basically deal with any situation that comes, and one of the major barriers that is often the people encounter is systematic discrimination, including race and ethnicity. So people have, for example, been taking the class under the influence. It's not a cat or mouse game to see whether you can get away with it. It's your life. But these people, by and large, actually have been European American. So should I consider that disrespectful of me being a black professor? So if you cannot stop using addictively by the medical definition of addiction, you should get out now while the getting's good and it doesn't cost you more money. So if you're staying, I expect you to perform with a certain level of level-headedness, and this is life and death stuff we're dealing with, and the discussion of race and ethnicity is also tricky and difficult, but that's why I'm starting with it, because that's part of the praxis that I was raised with. So, for example, a biopsychosocial is a clinical evaluation. That's the standard. You take a person's story, convert it into medical language, create a treatment plan so that the person can have a healthy outcome. That means they have to understand, and any medical professional can understand what the diagnosis is and what the course of treatment is. Now, if people are self-medicating for emotional problems, you have to understand the culturally appropriate treatment for those medical problems. What if your culture did not train you to deal with racism on a daily basis? Certainly, if you're a woman, you learned how to cope with the sexual advances of men as part of your training. Right? Give a phone number, give a fake phone number, I'm busy that night, etc., etc. You learn to do that kind of stuff. What about for race and ethnicity? Right? And how does that fit into a biopsychosocial? So part of the descriptor of a biopsychosocial is going to be not only a physical description of the person, but if there are obvious things that the clients either bring up or don't bring up. If you're going to do a biopsychosocial on me, one of the first things that you notice, oh, you're a brown person. No, don't refer to me as a brown person. I'm not Chicano. Say black. It's the 21st century. You can say black or African American, or you can ask me. Or actually, theoretically, you should know what the current 21st century term is and be comfortable with using it. How do you like to be identified? And I'll say, well, I greeted you with Halito. I'm a black Indian, but you can just refer to me as black. Right? That's going to be part of your biopsychosocial. So, for example, a CT, client patient, presents with a certain CT-PT presents with a certain SX based on their HX. So a client patient presents, that is, shows up with and displays SX equals symptoms and a HX history, what they say happened to them, and which may not be everything that happened to them, just what they are aware of or willing to trust you with. So I can tell you one of the things that is critical to successfully treating a client of color is if they visibly look like something, you ask them if they have experienced racism. You can ask that question directly, particularly if it's a black client. In fact, I will tell you, black clients won't trust a white practitioner that does not raise that issue first. Because if you raise it first, it shows that you're comfortable with it, or at least willing to talk about it. Okay? Not in denial. Right? They may be taking RX, prescription drugs. So you have to factor for this within the treatment plan and as part of TX, treatment. You have to be able to predict as well as explain to the client what the diagnosis is, even when you can't make a diagnosis. So as an example, there is no diagnosis for recovery from racism, though racism is part of people's daily lives. So early on when I spoke last week about as far as the medical science goes, the medical science does not recognize that racism or sexism has a psychological impact, but we know it does. So there is science to address it. So this has to be added in. So I'm operating on the assumption that somewhere in your career, you'll meet and treat a client of color, and I want you to be successful with dealing with them. And this is based on the science, because I come from a lineage where we are black practitioners, and we have to deal with not only black people, but all people, and be competent with them. We're part of the medical field. You want to have a particular advantage that others don't have. So I'm making you employable, too. All right? So I can't make diagnoses. There's no diagnosis for recovery from racism. But I have to know what their appropriate diagnoses are and be able to guide them on a path towards healing. So as an example, you may have noticed, so people make appointments with Mark Harris all the time. And so one day a woman was making an appointment with me, and she walks into the office and she goes, "Oh, you don't look the way you sound." So I was in a playful mood, so I said, "I sound taller?" "Yeah." "How did I look in your mind's eye?" "Blonde, 6'2", blue eyes." Now, this is a type 2 microaggression. She didn't know that, but that's what it is. So essentially, I don't look the way I sound. I sound taller, yeah. How did I look in your mind's eye? Blonde hair, blue-eyed. All right, so obviously I'm not blonde hair and blue-eyed, but I sound the way I sound. I speak California newscaster English. And so, to continue with the story, of what I said with her is, well, I can make my voice sound white, but it's black at the roots. And then, she blushed, ha, 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 ha. And there were two other students, one Japanese and one white, to set the context, who are my ethnic studies students. So I said, I was talking with someone else, and I was talking about the subject turned to racism, and they go, "I detect you're African American." Go to slide. "I detect you're African American." Wow, caller ID technology has come a long way. Well, you detect I'm African American because I'm talking articulately, and this is what the woman was saying. So this woman that said, you don't look the way they sound. And I said, "You must be from Oregon." She goes, "Yes, how did you guess?" Well, I come from Los Angeles, and this is how black professionals sound in Los Angeles, like this. You made an assumption about me being white because I'm supposed to speak with an Ebonic accent. So I detect you're African American. Like what? Because I'm talking articulately about racism, not necessarily being angry or impassioned. I'm just being clinical. I'm saying that racism exists. We actually have a whole catalog of how to detect and deal with racism clinically in clinical settings. Black psychiatrists, there have been about 100 years worth of them, have done that. So Rasmussen, in your book, puts culture as an afterthought towards the end of the book. And because you've got me, and ASAM, of course, as I mentioned, mentions culture as a dimension of recovery, but, a lot of times people don't make it to recovery. They are discharged for, as the phrase goes within 12-step culture, they are defocusing from recovery. And if they're dealing about, the woman has been called nigger bitch while she was being sexually molested by her white stepfather, and she's the only black kid in her class growing up in high school, and she couldn't bring that up, she's feeling racism, and that she's drinking to deal with that racism. It is a legitimate part of treatment. I can't emphasize that too much. So as an example, ASAM mentions culture as a dimension of recovery, and the problem with this is that if people don't complete treatment, they don't get to recovery. If they are discharged by treatment professionals for raising race as an issue as part of treatment, they don't get to recovery. That's too late. You have to raise the issue and deal with the issue of culture in recovery as part of the treatment process from day one. Because if you don't, you lose them. You lose them, simply. Right? So, I believe culture or a cultural deficit may sometimes be the cause of an addiction. So, for example, you are a MGT or PSSD or other cultural survivor. So MGT is multi-generational trauma. It first came up in Native American framework, basically to describe people who are survivors of genocide. PSSD, which is Joy DeGruy's contract, post-slavery stress disorder, because she was basically in her therapy class and they were describing PTSD, and she's going, startle reflex, hypersensitivity, hypervigilance. Wow, I know a lot of black people that are in that kind of situation, and they're in unsafe neighborhoods, and they never had a chance to heal from the trauma of slavery. So that's why she coined up with PSSD. It's basically, oh, well, slavery ended a long time ago, but people have still yet to heal from that. So other PSSD or other cultural survivor. So if that is the problem, which remains undiagnosed in the mainstream approach, I start from Jump Street, the jump, the get-go, the beginning. So that is the culturally defined science within communities of color, which have had addiction science older than Western civilization. Okay? Your addiction is a result of self-medicating, unresolved, attempted genocidal cultural destruction. You absorb the addictive patterns of the mainstream society because your pre-contact, non-addictive culture was destroyed in the process of colonizing Western civilization. This is true if you were Native. This is true if you're African. This is true if you're Latino. This is even true if you are certain European cultures from Europe that came over as immigrants. So, for example, the Irish, Germans, Russians, and many other populations who will stereotypically have high drinking rates, there's something that's driving those high drinking rates, and it's not because they like Oktoberfest. It's not because they like St. Patrick's Day. They experience cultural disruption of a very severe nature, and the memory of that is driving some of their substance abuse. Now, Western science doesn't acknowledge that is so, but other populations have noticed that is so for us. So, it's not limited to people of color, but certain other European cultures who've experienced war, cultural destruction, but had to resort to addiction to cope with hopelessness. Irish, German, Russian, Scandinavian, the list goes on. So, since, though, APA doesn't recognize racism or genocide or cultural destruction as having emotional implications, remember, medical science is only 150 years old. Genocide has been going on for longer than 150 years. We still are in denial about the effects of slavery psychologically. So, what about people who've experienced worse things than slavery for a lot longer? Right? So, though APA doesn't recognize racism as having emotional implications, certainly wouldn't recognize past historical trauma on present people either. Which is why the work on culture and addiction has been pioneered by people of color as a response to the non-response of mainstream society. So we've developed our own science for at least the better part of a century, and has existed in parallel to mainstream psychology. So that's part of my lineage. So, la cultura cura, culture cures, the dimension of culture. So we talk about cultural competency as a skill set. The idea of cultural competency, competent means that you're skilled, and there are a set of skills and capabilities that deal with the dimension of culture. That is, skill in navigating and utilizing the dimension of culture. It's a critical skill to learn in this field. And there are multiple levels and dimensions of culture. Probably too many to deal with in this lecture and the next lecture if we get into it, but I'm using a starting point. So the dimension of culture. Culture, again, is not race or ethnicity alone. The reason I'm focusing on race and ethnicity is because there is lots of literature about it. And the literature of people of color is instructive in terms of looking at that. Like Rasmussen, not a person of color, that's why she deals with culture as almost an afterthought. ASAM was not developed by people of color alone, so that's why culture is mentioned as a dimension in dimension 6, with the assumption that you don't deal with it up front. You deal with it as an afterthought in recovery. Well, the reality is, and the data bears me out, that many people of color, particularly African Americans, are not succeeding in treatment. And part of the reason they're not succeeding in treatment is that if their primary core issues are not being addressed in treatment, they're not going to stay. So if they learn to basically suppress, talk about racism in a 12-step meeting, in this community, then they won't raise it. And if there are 12-step communities in Portland where you have majority people of color and they do raise race as an issue, it is not ethical for me to send somebody from Eugene up there. It is not ethical for me to send a person of color to Portland for addictions treatment. They should be dealt with here. That's it. I'm saying it. All right? So culture is not race or ethnicity alone. But race and ethnicity are often the most obvious places to start algebraically. And what I mean by algebraically is simply using the principles of algebra. That is order of operation. If you translate the principles of algebra into, algebra literally means in Arabic, the mending, algebra. So basically, in order to do the mending, you have to go to the center of the greatest pain first. So you have to go to the greatest place of social of wounding. And with a woman, if we know that 75% of women in treatment have been sexually abused, we should be able to go there. If we know that many people of color experience racism, we should be able to go there, no matter what color we are. Okay? So, center of the greatest pain even for white people, or even people who are white identified. So, race and ethnicities are used as discriminators in American institutions, including the treatment field. Black practitioners do not have the option to be culturally incompetent or discriminate with white clients in Oregon. We do not. We have to be competent, culturally competent with white clients. We cannot be incompetent with white clients or else we get thrown out of our jobs. But white practitioners are not required, well actually ethically they are required, there are actual OARs that recognize that culture is a barrier, and the barrier of culture is not in the client, it's in the program. So the program is required to make accommodations for the person's culture. That means training and competency. You don't have to alter your programming, but you have to alter your attitude. So white practitioners frequently discriminate against clients of color because, sometimes deliberately, but mostly unconsciously, by statements like, "I don't see color." Well, colorblindness is one of the microaggressions that has been listed as a form of discrimination. It's not as intense as being called a racial name, but it is effectively discriminating as if you called them a racial name. Psychologically, they feel the wounding. So that's what we have to be, is client-centered. "I don't see color" is a lie. You look at me and you say, "I don't see color," I know you're lying. So then I don't trust you. So you need to go from color blindness to cultural competency and cultural proficiency. So when you say you're colorblind, you're actually saying you think you don't discriminate, you see it as well as somebody, you see a person's color as well as their gender. You feel uncomfortable with somebody, when somebody gender bends or cross dresses, and you feel uncomfortable with people who cross those boundaries. And if you think that white is normal because you're white, well, not everybody is white. Most of the planet is not white. White people are actually the minority planet-wide, and they'll be the minorities in this country inside of, well, certainly my lifetime, certainly in the next 30 years, even in this community. So, get competent the way most of us are competent to deal with you. So it's actually better to have skill with a varied color palette. So for example, if your computer is grayscale, no, we don't make grayscale computers anymore. It has millions of colors, right? Get with the program. Life is in Technicolor, not shades of gray. So learn to use cultural healing as part of your skill set by doing your own cultural healing work. Where did your folks come from? Where did your family come from? I can name 5 generations going back to slavery and beyond with the Native American folks. How many of you can do that? Who were your great-great-great-great-grandparents? Do you know that? And why don't you know that? So many cultures, particularly Africans and Latinos, as well as Native Americans, can actually name their families. Now, many Native Americans can't because of the cultural destruction that occurred where those people were killed and the memory of their culture was destroyed so that they were made to become American. So that's a healing work. So when I talk about my story, in fact, in terms of my degrees and my praxis, so BA and MA in psychology, 75% of a doctorate in public health with health promotion with minors in anthros and psych. So I'm a Maroon, which is the native word for an African-native hybrid. Maroons study history and culture as part of their analysis to come up with new solutions and new healing. So my lineage is with black psychiatrists who, reconciling the training of Western civilization in America as well as our traditional science, have had to make certain adjustments, which for me is reconciling Samuel Cartwright and Frantz Fanon, 2 different psychiatrists with 2 different points of view. So one of the, in a construct that I developed where you basically come up with a question of how do you help people? How do you help people when the only tools you have do not give practical resolution to their problems? So my training in psychology did not deal with how to deal with people of color, even though I was a person of color. It was frustrating. So for example, DSM-4R diagnosis does not exist for systemic neglect, particularly institutional racism. That's what the INT stands for. So this results in a lack of institutional and individual cultural competence and proficiency. Now, the reason I go there first is part of black psychology and psychiatry is we not only study the strengths of people, the cultural strengths that people have, we also study the barriers before them and prepare them in strength to cross over and go over those barriers. All right? So we look at the barriers first. And we train, so, okay, this is how this barrier is structured. This is how you're going to be able to go over it. All right? So here's how we'll deal with that. We will teach you, okay, the barrier exists. It's structured this way. So you're going to need a ladder at this front end, and you're going to need to brace yourself for a hard landing when you come down. Okay? Maybe you'll be able to break down the wall, but the wall might be too thick. Maybe there's gatekeepers before and after the wall. You're going to need to know the right code words, the right ways of speaking to begin to go through that barrier. But we train you for the barriers first to go through them. Because you can go through them. You have the strength and the abilities and the skill to do that, and we'll tell you about historical role models so that you know, oh, well, other people face this exact same problem and they made it. How can I do it? All right? So part of that institutional and individual cultural competence and proficiency. So, for example, if you're bipolar, you have attachment disorder, PTSD, you're dual diagnosed, you have gender identity dysphoria, these are all things out of DSM, is your only hope medication? What does the medication do to help you deal with bipolar, attachment disorder, PTSD, dual diagnosed gender identity dysphoria? How do those things help you? Now, originally the theory with medication is that it was going to be combined with talk therapy to talk you through the problem, and that the medication was only supposed to stabilize you while you got talk therapy. Well, Big Pharma basically made it so we only get drugs and no talk therapy. So there's pills, but not skills. So I needed a new model. So I created one from available parts, and I call this model axiochemistry. So how you define it? So there's a branch of philosophy called axiology, which is basically the study of values. Chemistry is the study of and the relationship between exogenous, that is outside of the body, chemicals, and endogenous, inside the body, chemicals on the human spirit. So now we're even talking about here it's human spirit. I'm not talking in religious terms. I'm talking as a transpersonal psychologist. That's my particular concentration within psychology. That is transpersonal, beyond the person. That is, the beyond exists. We can talk about it. The human spirit exists independent of the physical body. Right? We talk about that in general terms. So, from Kemet, or Egypt, from where the technology to create distilled spirits was derived, and the cultural values, laws, science, and policy regarding those spirits' effects